Hey guys, welcome back to Medical Coding with Blue. Okay, today's episode we're going to be talking about use, abuse, and dependence. So this episode is really handy for when you're trying to figure out whether to code for use, abuse, or dependence. So whether we're talking about a substance that the patient is using, like drugs or maybe alcohol or caffeine, something like that. Distinguishing when to pick up what, okay? And we're going to break down what each use, abuse, and dependence, what does it mean when we say that the patient uses a drug or the patient is abusing it, or if they are dependent on it. What does it all mean, okay? Now, none of this is official, but I am just a veteran medical coder sharing the things that I know. I've been in the industry for over a decade, and I really love what I do. So if you are into coding mental health and you are in that section, or if you are a coder right now that is coding for mental health, this is something that hopefully will help you. If you have any questions, please be sure to comment below and ask me. I will leave my email address also in the description box below. So if you have any questions and you don't want to put them on, on my channel, it's fine. Just email me and I will get back to you as soon as I can. All right, so let's go ahead and get into this. Now, when a patient documents use, abuse, or dependence of the same substance, you must go through the hierarchy to select the correct diagnosis, okay? So let's cover the severity of each: use, abuse, and dependence, okay? Now, sometimes before I get into that, a provider will use more than one word when they're describing a patient's use of this drug, okay, or use of alcohol, or whatever the case may be, or caffeine. And so sometimes when they use them interchangeably, use, abuse, and dependence, then you need to make sure that you're coding the correct one according to the hierarchy. But let's talk about what each one of them means, right? Or get you to think about what each one is like sort of referring to. So maybe that'll help you. Use is saying that the patient uses a substance, like occasionally. Sometimes the patient will say, well, I only smoke when I drink. So they're not abusing tobacco, but they're not dependent on it. They're just using it socially. Okay. So that's generally what using means, right? They don't really need it, but they do use it recreationally or socially, okay? Generally, the patient wouldn't go through withdrawals if they were just using, like I said, using the tobacco only when they drink. They don't really go through withdrawals. They don't need it, okay? Abuse. This is like saying that the patient is using the substance a lot. It is more recurring thing, perhaps more than recreationally or socially. Sometimes they are sneaking around to do it. Okay, that's usually like when they start noticing that a patient is abusing. Okay, it's one of the indicators. They need it a little bit more than just regular using, and they are at a higher or moderate or higher risk for withdrawals. So if a patient is abusing something, whether it is like drugs or alcohol or caffeine, if they're abusing it, if they don't have it, they're gonna, like, their body is going to go through withdrawals. So that puts them in a moderate or higher risk for withdrawals, okay? Because this is a more recurring use, okay? They're just abusing it and it's sort of spiraling out of control, okay? That's what the things that you can think of when you think of somebody, or when you see documentation that says abuse. That's sort of what it is referring to, okay? Because it's just, as it goes on, it's just getting more and more and more intense, okay? All right, and then the next one, or the final one, is dependence. That when they say that the patient needs it, sort of like when the patient can't go through their day without it, okay? They get violently sick if they don't have it, and this puts the patient at a higher risk for withdrawals. So when they don't have access to the substance, whatever it is that they're dependent on, then they can just get violently sick. Or maybe they get really edgy and, just really grouchy. Those are symptoms of, a patient who is dependent on a substance. So I will go into a story time before I go on to the next part. A few years ago, I was diagnosed with acid reflux. Okay, it just happens. Okay, so in order to get better control of it, they said, okay, we need you to stop or slow down on your caffeine intake, because I would have coffee in the morning and then I would have tea. So coffee and tea is mostly what I would get through the day with. Okay, and I noticed when I didn't have caffeine, of course, I would get a headache. Like if I would wake up Saturday morning and then just go do a bunch of errands, and then by the end of the day I'd have a pounding headache, and I was like, why do I have a headache? Because I didn't have coffee that morning. I hadn't drank tea. I had mostly drank water. And so in those instances, I was like, oh gosh, I have this headache, and now they're telling me that I have to stop with the caffeine. And my doctor has said, don't go cold turkey. Whatever you do, don't go cold turkey. Well, I went cold turkey because I was reading and researching, and they said that the best way to stop anything is to just go cold turkey, because it's going to take you longer. And the reflux was just bad, and I just wanted it to stop. So I was just like, okay, if I go cold turkey, let me just make sure that I drink plenty of water, and that I take like a Tylenol or some other pain reliever in the morning just before, so I don't get a headache. So I said, okay, well, I can do this. And it was like mind over matter, right? And I didn't really realize how serious caffeine dependence could be. So here, learn from me, okay? So the first couple of days, I was like, okay, well, I'm doing okay. I don't really have a headache because I've been taking the Tylenol and I've been fine. And about day 3, I was like, okay, I'm still doing good. Day 4, I was like, all right. And then day 5, like the Tylenol started to not work. And I was just like, uh-oh. And I was like, well, it's okay. Just push through it. By day 6, it really didn't work. And I was just like, uh-oh, like I'm literally in trouble now, because like I could feel like my body started to ache. And not only did I have a headache, but I also had body aches now. So I switched over to Motrin, and hopefully like that would help me. It didn't help me. By the 8th day, I literally got up to go to work, and I literally could not get up out of bed. I was literally like, my whole body, everything ached. My head was pounding. I was literally like in such pain that I was on the verge of tears when I called into my boss. I was like, I'm not coming in because I literally cannot get up out of this bed. And like my neck and my legs, everything, my arms, everything hurt. Every single inch of my body was in pain. And this was from not having any caffeine. For somebody who had a cup of coffee in the morning and then maybe 2 glasses of tea, like one for lunch and then one for dinner. And that was my whole day. I had 3 servings. Well, actually, probably more like 5 if you make them like it's like 6 ounces, 6-ounce serving. So it was like maybe 5 servings a day of caffeine I had. You know what I mean? Like I had literally 1 cup of coffee, which was maybe a 12-ounce cup. And then the rest of them was like, 24, or, 12 or whatever, But it evened out to like 5, 6 servings of caffeine a day. That's what I was doing to myself. And I was just like, my whole body just could not take it. I was like, okay, well, I need to do something, because like nothing I was doing was working. I couldn't take Tylenol anymore because it was literally not doing anything. Motrin, nothing helped me. So I called my doctor, and after I got off the phone with my boss, I said, I'm in pain. Like I need help, And so I went to my doctor, and she said, what did you do? I said, I have not had caffeine in 8 days. This is the result. And I was literally could barely walk. I was just in pain, And she goes, you are going through withdrawal. And I said, I didn't know it was going to be this bad. And then she goes, okay, so we got it all straightened out. And I felt better after that. But she was literally like, you should have went like a little bit at a time. I said, I just want the reflux to stop. And I don't know what else to do. She was like, okay, Blue, we're going to get this going right for you. But, you know, she goes, that was really hard. She goes, did you learn your lesson? And I said, yes, I did, because withdrawal is not a joke, okay? And this was just caffeine. I mean, I can't imagine, you know, the pain from something else, you know, but it was crazy. And so I understand dependence, all about caffeine dependence, okay? So after that, with my doctor, after she got me all straightened up and everything, I did stay off the caffeine for a good 5-6 months. I mean, literally, I had no caffeine. And caffeine does a lot to your body, believe it or not. It messes with your metabolism for sure, because when I completely got off of caffeine and I was okay to be off caffeine and my body had adjusted to this horrid thing that had happened, I lost like so much weight because my metabolism just went up, and it was literally from not having caffeine. So that's another thing, just sort of interesting about caffeine, is that it while it's good, if you abuse it, it can be bad, you know. And so, you know, but anyway, now I go back to coffee, but I am very careful about the amount of caffeine that I do take in. I at least let myself have coffee in the morning. Really, the rest of the day is just water. I don't drink sodas too much anymore. Like, it's very rare that I have a soda, but I mostly drink tea. And if I drink tea, I will, you know, put very little sugar in it. And, you know, it's fine now, but I'm definitely not as dependent as I used to be when it comes to caffeine. But yes, that dependence really, if I would have seen how it was documented, the patient abuses caffeine. She is dependent, you know. So anyway, but yes, that was my little personal side story on that one. Not to get distracted, but anyway. So yes, caffeine, it can be totally a substance that you can be dependent on. I'm just saying. All right. So then moving right along. So the hierarchy goes as follows. If both use and abuse are documented, assign only the code for the abuse. Okay? Because remember, use was only like occasionally. Abuse is where they're kind of having to use it a little bit more and they're sneaking around to do it. Okay? So if you have use and abuse being documented, then you're going to code for the abuse. Okay? If both dependence and abuse are documented, you're going to assign only the code for the dependence. Because now, again, it's going up in the hierarchy, okay? So if they say that the patient is abusing something and then they're dependent, you're going to code the dependence. If both use and dependence are documented, you're going to assign only the code for the dependence, because dependence trumps that use, okay? Remember, use is like lowest of the low. Then it's abuse. Then it's dependence, okay? And then if all three are documented, use, abuse, and dependence, you're only going to assign the code for dependence, okay? Because out of all of those, the highest level of that is the dependence. So that's why you're going to code the dependence. So here's some examples. I've included 5 examples, all right? So if the provider states, or the provider states in the patient's HPI that the patient is opioid dependent with ongoing opioid use, you would not select both diagnosis codes. You would simply refer to the hierarchy and only code the opioid dependence. Okay, that would be the one that would be picked up, the opioid dependence. Okay, and then the next one is the provider states in the HPI that a patient is alcohol dependent for the last 10 years and has been attempting organic detox and is suffering from withdrawal seizures. The patient notes in the A&P, or the assessment and plan, that the patient's chronic alcohol use is causing withdrawal seizures and confirms that the patient does not have epilepsy. The code selected would be the alcohol dependence with withdrawal. Why? Because the dependence trumps the use. So you see how that came together? The patient was doing organic detox and is suffering from withdrawals suffering from withdrawal seizures from the alcohol. So right there it says that they are alcoholic dependent and they are having withdrawal seizures. Okay. So that's how you pick up that. And then the next one is the patient is a longtime cocaine user. After successfully completing a rehabilitation program, the patient's cocaine abuse is now in remission. What would the code be for that? The code would be F14.11, cocaine abuse in remission. Okay, because there's cocaine abuse and then there's cocaine dependence. Okay, but since all we said is that the patient is a long-term cocaine user, then the patient's cocaine abuse is now in remission. That's why we would pick up the cocaine abuse in remission. Okay, because abuse trumps use. And then the next one is the patient has been abusing hallucinogens. The provider states that due to the patient's hallucinogen dependence, they will be referred to outpatient rehabilitation. The diagnosis would be hallucinogen dependence. I don't know why I got tongue-tied on that one. But see how the patient started from abusing. The patient was abusing hallucinogens. And but due to their hallucinogenic dependence, they would be referred for outpatient rehabilitation. So once he said that dependence, that automatically moved the patient up the hierarchy, okay, from abuse to dependence. All right. And then the last one is, what is the ICD10 diagnosis code if the provider only documents tobacco abuse? Are you ready? Z72.0, tobacco use. Tobacco is listed in the book under use or dependence. It doesn't, and when you access the book, it directs you under tobacco abuse to see tobacco use. This is when querying the specificity of which type of tobacco or working with your providers to be as specific as possible would be beneficial, because there's no code for tobacco abuse. When you look in the index, it'll tell you to see tobacco use. And when you go to tobacco use, it's going to give you that Z72.0 code. Okay. This is when you have to look at the documentation. If they say that the patient is a smoker, according to the book, you would not automatically select that F17210, which is the tobacco dependence on cigarettes, okay? Because we don't know what kind they are, what they are. Even though they say it's a smoker, yes, we don't know if it's cigarettes, cigars, or vape. We don't know, okay? And so since we don't know, we can't assume that they mean cigarettes, okay? So that's why it would be F17200, which is the nicotine dependence unspecified, okay? So something you have to go through and look at very closely. And if it's confusing for you, it's okay. It's understandable, because everybody goes through that. And when I first heard about that use, abuse, or dependence, I was like, oh, really? But yes, it does get to be a little bit, okay, now I got to think. Now I got to think. Now I got to think. But at least if you know the order, use, abuse, and dependence, and you can sort of wrap your head around that the use is they're occasionally using it. They use it like when they're out with friends. It's like recreational. That's what they mean when they say that, okay? If they're abusing it, you know, they're having to use it a little bit more, and it's just getting a little bit more in depth, you know, a little bit more intense in their use of it. So if they're abusing it, they're kind of sneaking around sometimes to do it because they have to do it even more, okay? When they're dependent on it, they have to have it. They have to have it to help them get them through the day. or if, you know, they're just dependent on it. They can't, you know, they can't function without having it. And you see from my story about being so dependent on caffeine, I literally could not function because like I said, that pain was miserable, and it was just like something that was just not going to go away. And I mean, it was horrible. So I understand, you know, but that's, I mean, and so going through withdrawals is something that people who are dependent are at a higher risk for. So I hope this helps. If not, hopefully you can remember my story. But yes, it does happen even with caffeine. It can happen with chocolate. It can happen with a lot of things, you know, drugs, alcohol, sex, anything. I mean, addiction is addiction. And understanding the levels of addiction is really important, because then if you really understand, then you can really start to dig in the provider's documentation and make sure that you're coding it out as specifically as possible. Okay? Just saying. This one was pretty fun, right? Anyway, I will go ahead and close this video up. But tomorrow is Quiz Friday. I'm excited about Quiz Friday. Do I have something up my sleeve? Maybe. I don't know. We'll see. You'll have to tune in tomorrow. But I will be filming on the weekend too as well. I have a few episodes planned for the weekend, for Saturday and Sunday. So look forward to that. Thank you guys so much. If you are new to my channel, I so appreciate you. If you've been with me since the beginning and you've been with me in the ramp up period, I really appreciate it, guys. Thank you so much for joining me. I really appreciate it. I really appreciate all your support, all of your questions, because not only do your questions help other people, they do help me, because it helps me to get more sharper in how I'm explaining things, and then how I have to break things down a little bit more at a time. So I really appreciate it. And I can't thank you guys enough. I really do appreciate y'all. And you can join me on Instagram. I'm on Instagram at medicalcodingwithbleu, all one word. I am also on Twitter now at codingwithbleu. It's BLEU. But I am on Twitter now. And you can join me on Patreon. I have a channel on Patreon where it's a little bit more in-depth blue. And I am going to have some other in-depth stuff. My next episode for Patreon is going to be a catch-up, and then it's going to be a episode about sequencing. So that's going to be coming up on that as well. So I will go ahead and close this one up. But if you are a medical coder, a medical coding student, somebody curious about the fascinating world of medical coding, a provider or a nurse, I invite you to like and subscribe and follow me on my journey in medical coding. I will see y'all on the next episode. Bye!